So, in our last discussion, we had actually talked a little bit about the generalized overview of what inflammation is, the process, its types, somewhat the etiology of inflammation, and along with that, we had talked about a very general overview of the mechanism of inflammation. We hadn't gone into the details of the inflammation processes, but we had just talked about generally what happens, the 5 R's. Right. So, in this discussion, we would actually talk about in detail what goes on in the process of acute inflammation. But before going on to that topic, let me actually get a very small topic out of the way, which I should have covered in the last video itself. That is the cardinal signs of inflammation. So, the cardinal signs of inflammation. What does this mean? See, in our last discussion, I had said that there is some local or systemic effects which are seen in case of acute inflammation, which is very marked in acute inflammation, but not so marked in chronic inflammation. Let me give you a recap. See here, the local and systemic signs, they are prominent in case of acute inflammation and not so prominent in case of chronic inflammation. What does this actually mean? Pertaining to that, we have to talk about the cardinal signs of inflammation. Inflammation is a process which is going on, and that is actually a kind of a response which our body is showing to some kind of noxious stimuli, right? In response, our body is doing something. So, externally, we are able to see certain manifestations, certain physical manifestations of inflammation. These actually constitute the cardinal signs of inflammation. If you see these things happening, you can be pretty sure that inflammation is going on or that site is inflamed. What are these cardinal signs of inflammation? There are majorly 4 cardinal signs which are given for inflammation, plus one extra cardinal sign is also there which was added later. What are they? Number 1, we say it is a tumor. Tumor means swelling. Okay. Number 2, dolor. Dolor means pain. Number 3, calor. Calor means heat. And number 4, rubor. Rubor means red. So, at the inflamed site, we will see swelling. There will be pain at that site. That site will get locally heated up. So, heat here does not mean that our body would heat up and we will be in a fever state. Rather, that site where we probably have sustained some kind of injury and hence inflammation is going on, that site will get heated up. So, local heating up, and that site would also become red. Now, we can already match with our experience of injuries, right? This is what a wounded site looks like, a wound looks like typically. So, these are the 4 cardinal signs of inflammation. These 4 were given by a person named Celsius. Okay, I wrote it wrong, I'm sorry. Celsius. So, there was a person, Celsius, about 2000 years ago. It's pretty interesting to see that 2000 years ago, these cardinal signs were actually noted down by a person. And 2000 years later, we are studying the same thing. But later, in probably the 19th century, might even be 20th century, I don't remember. Point is, a lot later, there was another cardinal sign which was given. This is functiolacia. Functiolacia means loss of function. Loss of function. This was actually given by Rudolf Virchow later, a lot later, and it was later introduced as the fifth cardinal sign. The fifth cardinal sign of inflammation. So these are more or less the external manifestations as seen in acute inflammation, because acute inflammation is the one which shows these cardinal signs very markedly. Chronic inflammation has been going on for months and years. You won't see a progressive tumor, or always there is pain, always the entire body is heated up, stuff like that. You won't see that. Okay, there the manifestations are a lot more hidden, although the damage is a lot more pronounced than in acute inflammation. So anyways, we have already talked about that in our previous discussion. Now let's move on to what we should be talking in this discussion. That is the actual process of inflammation, or rather acute inflammation. So remember that I had talked about the 5 R's. The first R was recognition. So let's talk a little bit of recognition. Recognition of what? Recognition of the noxious stimuli. So what is that noxious stimuli in inflammation? What is that stimulus? It can be some microbe, it can be some necrotic cell, okay, or it can be any foreign substance. All of these are stimuli. For what? Let's take another. Yeah, so all of these are stimuli for inflammation. But how exactly are these recognized by the sentient cells, the sentinel cells, the macrophages or the dendritic cells? How do they actually recognize these? Let's talk a little bit about that. We won't be going into much details. So interestingly, we have seen that these microbes or necrotic cells, what they will do is they will actually release certain factors, certain chemicals, which were informally known as danger signals. Danger signals. Informally, they were known as danger signals. These danger signals were actually picked up by the cells which we say to be recognizing the noxious stimuli in the first place, like the macrophages, the dendritic cells, etc. But what do these macrophages or these dendritic cells or all the cells, all the types of cells which can recognize these kinds of danger signals, what do they have? What do they specifically have which can recognize this? They have certain very special type of receptors which have been aptly named pattern recognition receptors. Okay? Pattern, let me use a separate, yeah, let's go with this. Did I, oh sorry, yeah, pattern recognition receptors. So why have they been named pattern recognition receptors? Because these receptors, they are actually recognizing molecular patterns. They recognize, let's write this in white actually. They actually recognize the molecular patterns which constitute the so-called danger signals, which are given off by the stimuli, the microbes, the necrotic cells, or the foreign substances which induce inflammation. They actually, these pattern recognition receptors, recognize the molecular patterns in them. Now it has been seen that these pattern recognition receptors, they are majorly of two types. Majorly, there are very two important families. What are they? So, 1 and 2. What are they? Let's use another ink for this. Let's go with red. Yeah, sure, why not? One is known as Toll-like receptors. Toll-like receptors. And the other family is called, this is very famous, Inflammasome. Inflammasome. Okay, so we have Toll-like receptors and we have inflammasome. Let's talk a little bit about each of them. So what are these Toll-like receptors exactly? See, Toll-like receptors, again, like the name says, it's a receptor. But what the name does not say is that these Toll-like receptors, also abbreviated as TLR, by the way, these Toll-like receptors, they have both, they are found on the cell membrane itself, and they are also found on endosomes. The implication here of this knowledge is that by the cell membrane component, these Toll-like receptors can detect extracellular stimuli, and by endosomes they can actually detect the intracellular parts, the intracellular stimuli. Okay, so what exactly does this Toll-like receptor actually recognize? Again, it's pretty simple. They can recognize the products of the microbes, which can be bacteria. What exactly of the bacteria? The bacteria, for example, endotoxin, or the bacterial DNA. These can be recognized. Again, for viruses also, it can recognize the viral viruses mostly have RNA, so RNA, right? Not just bacteria, viruses, other pathogens as well. Okay, so these are all stimuli for the Toll-like receptors. Okay, and they are found on both cell membrane and endosomes. Done. Now, what these Toll-like receptors would do is, these Toll-like receptors actually, they are actually linked to some other components which upon recognition, the Toll-like receptors, what they will do is, they will initiate some transcription and subsequently translation, and that will actually bring about the formation of certain proteins. These proteins, either they themselves will be mediators of inflammation, or they then would go on to recruit the cells which can then initiate inflammation. So here the point that I am trying to make here is that at the end of the day, Toll-like receptors, upon recognizing the stimulus, they will bring about transcription, translation, and the formation of certain proteins which will later mediate inflammation or lead to something which would then lead to inflammation, to initiate. So that is more or less everything about Toll-like receptors. Now, as far as inflammasomes are concerned, inflammasome It is a multi-protein cytosolic receptor, or rather a cytosolic complex. Okay, so it is a multi-protein cytosolic complex, and this will recognize what exactly? It will recognize obviously the products of dead cells, and what will those products be? They will be products like the uric acid or extracellular ATP, crystals and microbial products. So a very important information regarding the inflammasome is that inflammasomes, what they will do is they will actually trigger or rather activate an enzyme called caspase 1. Caspase 1. This caspase 1 will later lead to the activation of interleukin 1 beta. So inflammasomes will actually activate caspase 1 enzyme. They will then lead to activation of interleukin 1 beta. We will later find that interleukin 1 beta is a very potent mediator of inflammation. So it is a very potent mediator of inflammation, and thus it's no surprise that inflammation will initiate, right? Why is this knowledge important? Now you might ask, what is the implication of this knowledge? Why should we know about all this as doctors? In gout, we know that urate crystals, they are deposited. These urate crystals are actually engulfed by macrophages, or not just macrophages, I might say, let's say phagocytes in general, not just macrophages, but phagocytes in general. Phagocytes. Why? Because urate crystals are foreign bodies, so for that. Now, inside the phagocyte, site means cell. So, within the cell, intracellularly, there will be the multi-protein cytosolic complex, which is inflammasome. So, inflammasome will be present inside the phagocytes rather. And what these inflammasomes will do is, upon getting the stimulus that yes, there is urate crystal here, which is not a component or not a normal component of the body. So, of course, what they will do, they will lead to interleukin 1 beta formation, and this will initiate a very dangerous kind of inflammation, because it's hard to rid of this urate crystals because they have deposited and they have been internalized by the phagocytes as well. So now that would bring about a lot of destruction, and thus gout is very painful. And thus, as doctors, we know all of this so that we can then diagnose this and propose the treatment to be anti-interleukin therapy. So, anti-interleukin medication should be given. If the normal anti-inflammatory drugs don't work. We'll talk about this in a lot more detail, obviously, as you can already guess, in pharmacology. Okay, we'll talk about drugs for gout, rheumatoid arthritis, all of that later. So this is a very cool, you might say, vertical integration, right? We are seeing the pathology in so much detail. Along with that, we are integrating the knowledge of pharmacology. So it's pretty amazing to see, and it's very logical. So all you need to remember here is that Toll-like receptors and inflammasomes, they are both families which are under the pattern recognition receptors. Their task here is to recognize molecular patterns. Their task here is to recognize the stimulus which will bring about inflammation. So Toll-like receptors have cell membrane components as well as endosomal components. Okay, and inflammasome on the other hand, it is completely intracellular. It does not have, it's not present on the cell membrane itself, rather it is within the cell. So it is a multi-protein complex, and it is actually bringing about the formation of interleukin 1 beta, which is a very potent mediator for inflammation, and thus has application in gout. Now let's start with the actual inflammation process. We had talked about the first R, right? The second R was recruitment, and the third R was removal of the offending agent, right? These are more or less constituting the actual bulk of the acute inflammation process. So now let's start with the actual inflammation process, or rather acute inflammation. Because we are not talking about chronic inflammation just yet, let's move to actual acute inflammation, and then we will later come to chronic inflammation. So what is going on in the process? So let's use this. The actual process, the process of acute inflammation. What is going on? See, the first thing that you need to remember here, and yes, I do say remember, although it's not very hard to remember it, is that acute inflammation, this entire process or pathway, it has two major components. There are two major, you might say, parts which are being affected by this acute inflammation. One is the blood vessels, and hence the changes pertaining to them constitute what we say to be the vascular changes. And the second is regarding the white blood cells. So their changes constitute the cellular changes. These two together constitute acute inflammation process. In this discussion, we'll talk a little bit about vascular changes. So now, as you can see, we are back with red. Vascular changes. Vascular changes, what does this actually mean? Okay. It means the changes, obviously from the name itself we can say that it's regarding the changes that is going on in the vascular section. Vascular means blood and blood vessels. So blood and blood vessels, both, there is something going on in them. What? See, for understanding what is happening to the blood or the blood vessels themselves, you need to understand something. Suppose, let's go back to white for now. Suppose that this is the site where certain microbes they have entered. Okay. So these microbes, upon entering our body, some of them will obviously get on the bloodstream. Okay. Suppose this is the blood vessel. Now obviously this blood vessel, it is lined by endothelial cells, right? Flattened endothelial cells, and blood is flowing, blood cells are flowing through them. Now try to understand something. The microbes which will be encountering the white blood cells within the bloodstream itself, they will be finished here itself, no problem. But there will be some microbes which will be not in the blood vessel itself, rather outside the blood vessel. For that, these WBCs, they will need to reach them. This entire thing is actually what the entire process of inflammation is about, or rather the acute inflammation is about. Firstly, the first component, the first step is for the WBCs to reach the site where the infection has taken place, or where the bacterial load is very, very low. That constitutes the reaching of WBCs to that site within the blood vessel. That is actually constituting all the changes which are happening for that. All the steps, they are actually constituting the vascular changes. Don't worry if you are having any confusion right now. A lot more detailed overview will be coming in just a minute, so don't worry. We are just setting the ground right now. This is constituting the vascular change. Whereas the second component is the WBCs reaching extravascular offending agents. All of this is constituted by the cellular changes. Okay, now let me elaborate a little more. When, suppose this is the normal blood vessel, endothelial cell, 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 and you have certain bacteria or microbes, they have invaded our body within the bloodstream. So immediately what the blood vessel would do is it would start recruiting. Obviously there will be mediators of inflammation, and immediately what it would do is it will try to actually bring the WBCs to that site. How is it going to bring about, or how is it going to concentrate more and more cells in this site? By vasodilation. By vasodilation. Okay. So these are the endothelial cells, and these are, suppose, the offending agents. And now since there is vasodilation, there is a lot of blood and blood cells which have reached this site. Okay, this would mean that there will be more white blood cells as well. So this is kind of a way of the body to bring in more and more host defense mechanisms. But even before this happens, there is something else that happens. Let me erase this. Now that you know what should logically happen, let's see what really happens. Okay. So see, actually from this, the first, okay, this, from 1, this is not 2. No, this is not 2. Why? Because there is something else that happens immediately after we sustain an injury. Because these bacteria, let's be logical here. How did these microbes enter our bloodstream? From some injury, from some wound, right? So what immediately happens at that site is not vasodilation, but rather vasoconstriction, reflex vasoconstriction, and very transient vasoconstriction. Okay. So this is the second step, very transient. So it normally lasts for only a few seconds. That is actually a defensive reflex of the body to actually limit the blood loss from that site. So this is the second step which happens in the vascular change, which is a reflex transient vasoconstriction. Then immediately after that, there is vasodilation. Why? Because now the body, more than limiting blood flow, it wants to remove the stimulus for its discomfort, you might say. So for that, what it would start doing is, it would be more dilated. That is, this is vasodilation. So vasodilation. Okay. Why? Again, let me explain to you why it's doing this. It is doing this so that more and more blood cells actually reach that site, and there is more accumulation, rather more concentration of blood cells and plasma proteins, which can later bring about the removal of these noxious agents. But along with vasodilation, there is something else that happens as well. What is that? This happens along with that, plus there is something else that happens as well. What happens? What happens is, suppose this is the vasodilated region. Note how the endothelial cells, these are the normal endothelial cells, but at the site of inflammation, there will be endothelial cell contraction, and the vascular permeability will increase. Okay, so very interesting to see what's happening here. The vascular permeability at that site will increase. So not only is there vasodilation, but vascular permeability increase as well. Why, or rather, before exploring why, how is the vascular permeability increasing? To answer this, there are a lot of actually methods by which that happens, but most commonly what happens is contraction of the endothelial cells. This actually increases the width, or rather this increases the space in between the neighboring endothelial cells, and for this what will happen is even more interesting. For this, protein rich fluid will actually move out of the blood vessel. A protein rich fluid, protein rich fluid, protein and cells as well, fluid moves out. Okay, this fluid that moves out due to vascular permeability increase in the process of inflammation is known as exudate. Very, very important. Exudate. This fluid will then accumulate in the extravascular spaces, or rather in the interstitial spaces. It will accumulate there and lead to swelling. This is seen as the swelling, which we had said as one of the cardinal signs of inflammation, tumor. Also, since we are talking about cardinal signs, I have said here that there will be a lot of, in this picture, there will be a lot of cells accumulation here due to vasodilation. So redness will be increased, and this will be seen as what? Erythema. There is redness in that area. This is rubor. Also, not only that, you can also explain the heat, calor, because there are a lot of cells here. So heat in this region also increases, the local heat increases. So rubor, calor, and for exudate, tumor, and obviously pain will be there because of the swelling of that area, and because your body at that time, the WBCs are fighting off, and there are a lot of destruction, dead cells, debris that's being formed. So pain receptors are also stimulated, and there is pain as well, dolor. Okay. Now we need to understand something here. Why exactly is the body doing all of this? That is the million-dollar question here, right? Why? At least we can understand why it did the vasodilation. Because now what our blood vessels they are trying to do is they're trying to accumulate as much blood like cells and protein stuff as they can close to these stimuli so that they can be effectively eliminated, right? Okay, but why does it increase the vascular permeability? Why? Because of what I had mentioned to be the cellular change, which we'll talk about in the next discussion. In the cellular change, I had said that these leukocytes, they also need to clear off the offending agents which are not in the bloodstream but rather in the interstitial spaces. So for that they need to move out, and to move out they need to move out from the blood vessel. That is actually a very long and elaborative process. So the vascular permeability needs to increase. Okay, so it's very, very important to see how this is happening. Now, due to the vascular permeability increase and due to formation of exudate, another interesting thing is happening. See, exudate, what's happening? We are seeing that proteins, they are moving out, fluid moving out. So the remaining fluid within over here, what will happen to that concentration? The concentration of that fluid, what will happen to that? It will thicken, the blood will start to thicken, and the cells which will remain, obviously this is a blood vessel, so initially in the normal blood vessel they were flowing, in this obviously there was flow, right? The cells were flowing, okay, but now what will happen is, since there is such a loss of fluid and the blood has thickened so much, the cells will start to settle down, and what we say to be stasis will set in. So stasis will start setting in. This is also a very important thing, because later we will see when we talk about the cellular changes that stasis is one of the reasons, or rather it is one of the components which constitutes, or rather which promotes, thrombus formation. We will talk about this later in a subsequent chapter as well, and also a little bit in the cellular change part in a subsequent discussion. So anyways, this stasis, this is actually a very important thing, because the leukocytes and neutrophils actually they will start to settle down, and hence the initially what was happening, again we'll talk about this in cellular change, but right now let me give just a general overview. Initially what was happening was that, suppose this is the blood vessel, initially blood flow in normal blood vessel is laminar, it is not turbulent, it's streamlined. So in that the cells are central, they follow a central stream, and the fluid is more towards the periphery. But now due to stasis, cells have started to come close to the boundaries, to the margins. Now I am saying cells, but what we are really interested in is the white blood cells, because white blood cells, they are flowing very fast, so you need to slow them down, and now they have come to the periphery because of stasis, so it is easier to slow them down. Okay, there are certain things which happen close to the, you might say, endothelial cells along the margin of the blood vessel, and this all would lead to expulsion of the leukocytes or neutrophils towards the offending agent, which is not present within the blood vessel itself. So all of this I am explaining because I am trying to actually make you people understand what the vascular changes are and why exactly our body is doing all of this. Okay, why exactly our body is doing all of this, that is why we are talking about this. Now I had mentioned that these endothelial cells, they contract, right? That is how you are actually getting the increased vascular permeability. But that is not the only way by which vascular permeability is increased. So let's talk a little bit about some other methods, including this method as well, endothelial cell contraction, of vascular permeability change. So what are they? First, let's write it down. Let's use this. So we are saying the vascular permeability change factors. Okay. So now, what are the factors or what are the methods by which the vascular permeability is altered? The first one we have already seen, it is by endothelial cell contraction. What is very important to note here is that endothelial cell contraction, this is a response which is immediate, very immediate and transient. So endothelial cell contraction, for example, you get a thorn prick. Suppose you get a thorn prick. So immediate there is an injury and immediately there will be endothelial cell contraction, which would be transient in nature. It is temporary. So after probably 1 or 2 hours, the endothelial cells will again regain their original configuration. So that is why endothelial cell contraction, it is so common, because most of the times the kind of injuries that we sustain, they are not very life threatening or not very severe. Most of the times it's normal cuts and bruises. That is why they are all constituted by endothelial cell contraction, and that is why it is so common. The most common method of inflammation, or rather the most common method of vascular permeability alteration. Okay. Now let's see some of the other things. Another factor, another way by which it's actually done is endothelial cell, not contraction but retraction. Now it's a little confusing, I know. Contraction, retraction, what's the difference between them? So it's kind of like this. Suppose this is the normal endothelial cell and this becomes a contracted endothelial cell. Okay, this is contracted. But retraction means more or less this. So they don't actually move, rather, but there is just some cytoskeletal rearrangement in like probably one of their borders, on one of their walls. So retraction is not that, it does not create that much space as contraction does. So this is something that you can say it is a retraction. So like I mentioned, this endothelial cell retraction is actually brought about by the internal cytoskeletal rearrangement. Okay, so cytoskeletal rearrangement, that actually brings about the endothelial cell retraction. But something that you also need to understand here is the cytoskeletal rearrangement is mostly influenced by cytokines. So all those infections, all those viral infections, because we know cytokines have a very important role to play for viral infections. So all those infections which bring about increased cytokine production would lead to endothelial cell retraction. Consequently, endothelial cell retraction is not an immediate, rather a delayed response. But just like endothelial cell contraction, it is transient. Okay, so it is delayed but transient, because after a few hours these cytoskeletal structures are reorganized into their original configuration and they will go back to their original configuration. Okay. Now, let's move on to the next one, which is direct endothelial cell injury. Now, suppose you have something in your body which is very highly damaging, so much so, the damage is so much that it is completely destroying the endothelial cells. And these damaged and destroyed endothelial cells cannot be replaced immediately. Obviously, that is obvious because that will take some time, but the destruction is at a much higher rate than the renewal. Then that would create some spaces and hence that would increase the vascular permeability. So what can be an example of that? Such highly damaging to host tissue circumstances. A very good example of this would be sepsis or septicemia. So in septicemia, what happens is bloodstream infection happens. Okay, so in bloodstream infection, septicemia, there is blood infection obviously, but this actually spreads throughout the entire body and there is a lot of toxin production. And these toxins will obviously damage the endothelial cells and thus high damage, so they cannot be replaced immediately. Very heavy. Now, some very highly damaging other than septicemia, other than an infection, yes, it can be a physical trauma, suppose burns, 3rd-degree burns, very highly damaging burns, right? So these are all examples where endothelial cell is injured so heavily and so fast, and this is the actual thing which I am trying to focus. So fast the damage is that it cannot be replaced immediately. Okay. Since the damage is this fast, so the direct endothelial cell injury will bring about vascular permeability alteration, which is again immediate. But unlike endothelial cell contraction, this time it is sustained. So try to understand what I just said. It is immediate because the damage is very high, very high. So immediately endothelial cells will start, we will start to lose them. So it is immediate but sustained because we cannot replace those endothelial cells very fast. So it is sustained. Another way by which vascular permeability is altered is actually kind of similar to the direct endothelial cell injury, and that is something which is mentioned in the textbooks as endothelial cell damage. So the difference between these two, the direct injury and just damage, is that here the damage is there, but it is more sustained damage. The damage is more sustained to the endothelial cells. It is not as volatile, it is not as strong damage as the direct ones. So a very good example of this is, this is a very typical example, sunburn. So a lot of time what happens is, many times sunbathing, after sunbathing, you know, hours of sunbathing, and the person comes back to home, and later in the afternoon or in the evening the person turns red. There is redness throughout the body. So that is actually an example of inflammation taking place due to endothelial cell damage, and that redness that can actually persist for a few days even. So this time the onset was delayed, because the damage was not that high, but the damage was sustained. See? So endothelial cell damage, that will actually lead to delayed but sustained inflammation. Okay. So these are the four most important ones. And among them, the first one, endothelial cell contraction, is the most important one because it is the most common one. But apart from them, there are some other minor important ones, not so important. For example, transcytosis, increased transcytosis. So what's happening in that? Increased transcytosis, in that proteins, there is transcytosis of proteins. How? By certain intracellular vesicular pathway. Intracellular vesicular pathway. So what exactly is happening here? Let me explain. For example, this is a cell, or rather this is the endothelial cell. Certain vesicles, they are there within the cell. What these vesicles are doing is they are fusing and they are forming a continuous channel. Okay, and through this channel the proteins can transcytose out. So this was the lumen and this is the extraluminal side. So the proteins can leave that. How does this alter vascular permeability? If the proteins are leaving the vascular lumen, then obviously what will happen is the oncotic pressure, that will actually decrease, which would mean the osmotic pressure would increase within the lumen or within the blood vessel. So this will actually in turn lead to increased exudate. Okay, so more and more exudate will leave because more and more fluid will leave now because oncotic pressure, because proteins are leaving, right? So oncotic pressure is decreasing, so oncotic pressure is increasing on the other side, so that will draw in more water, more fluid. That is actually altering the vascular permeability. Another one, this is a little more interesting. This is leakage from new blood vessels. So what's happening in this? See, I had said that inflammation is not just about removal of the offending agent, but it's about the repair as well. So in repair, what is happening is angiogenesis. Angiogenesis is one of the components. Angiogenesis means formation of new blood vessels. Okay. Now, when these new blood vessels are being formed, these new blood vessels obviously they have immature or rather new endothelial cells. They are immature. They haven't formed completely. Now, let me write that down, immature. So due to this, what would happen is the immature endothelial cells, there will be a lot of space, lots of spaces in between them. So they are very leaky when initially formed, and thus it's very obvious that this would actually lead to more and more leakage, and thus more and more leakage means increased vascular permeability in those cases, right? So this is more or less, these are the steps, or these are the ways by which vascular permeability is altered. Mostly they are changed to be more, that is increased. But we are talking about blood vessels. What about the lymphatic vessels? So let's talk a little bit about the response of lymphatic vessels. Response of the lymphatics. So what exactly is happening in them? See, it is very easy to understand what's happening. We know that the lymphatics within them, load is increased in inflammation. Why? Because obviously exudate will be there. It will accumulate, the fluid will accumulate in the intracellular spaces, and this, along with the proteins and the cell debris and all of that, they will need to be drained from those sites. This is carried out by what? The lymph vessels. Obviously. The lymph vessels, obviously. Right? All those cell debris and the fragmented cells, the broken cell products, the fluid itself which had come out as exudate, they are drained by the lymph vessels. Many times in certain very specific infections, such as infection by Streptococcus pyogenes, this is a very important example. Streptococcus pyogenes, in many cases of infections of Streptococcus pyogenes, it has been found that this bacteria, oftentimes what it does is it will invade, or rather during its inflammation pathway, the microbe is not only limited to the blood vessel or the extra vascular spaces, but it will also sometimes enter the lymph vessels. Okay? And the lymph vessels will actually carry these microbes and they will disseminate it. It will carry it throughout the body. And this would lead to what? Infection of the lymph vessel itself. Infection of the lymph vessel itself, which has a very fancy medical term. It is known as lymphangitis. Lymphangitis. Okay? Where will these lymph vessels drain? Obviously, we know this. They drain into lymph nodes. And accumulation of the offending microbes there would lead to the lymph node infection, which is known as lymphadenitis. Adenitis. So lymphangitis, lymphadenitis, both are often seen. Now the telltale sign for lymphangitis is streaky lines. So let me write it in red. We often see red streaky lines emanating from the we might say wound, or from the inflamed site. Red streaky lines. This is often a telltale sign that the wound is infected. The wound is infected because now it means that the lymph vessels are carrying that. That is what is causing the red streaky lines, which is coming out from that the wound site, the inflamed site. Okay, so this is often used by physicians. So that is the response of more or less the lymphatics, nothing more to talk about in them, and that is more or less the vascular changes. Okay, vascular change, we had talked about it now, and I hope you understood this. I hope I didn't miss anything. I now have to go and see if I have missed anything, but hopefully I haven't missed anything. And so thank you very much, and I'll be seeing you very soon. Thank you very much.